Good morning, everyone. We're going to go ahead and get started. I would like to welcome everyone to this event. My name is Funke Jenny Coco, and this is the second Links Live event. Links is a growing online community and resource sharing platform for people working to improve cardiovascular health across the world. It was developed in collaboration amongst Resolve to Save Lives, the World Health Organization, and the Centers for Disease Control and Prevention. We have an exciting talk for you this morning that builds on this year's theme for the United Nations General Assembly high-level meeting, which aims to accelerate progress towards universal health coverage. Our esteemed guest speakers today are Dr. Tom Frieden, the President and CEO of Resolve to Save Lives, Dr. Myrna Cabotaje, the Undersecretary for Health for the Philippines Department of Health, and Dr. Olugbenga Ogedegbe, the Professor of Population Health and Medicine and Director of the Center for Healthful Behavior Change at NYU. So following their presentations, we'll have a moderated discussion, and then we'll open up to the audience for any questions. This event is being recorded and live streamed, and after the event, it will be posted on linkscommunity.org. So I'm now going to hand it over to Dr. Tom Frieden, the President and CEO of Resolve to Save Lives, to introduce the topic and the speakers for today.
Thank you very much, Funke, and welcome all of you here in the room and online. Delighted to have you here. When all is said and done, all too often, much more is said than done. At no time is that more apparent than in weeks like this with the UN General Assembly, and for no topic is that more apparent than strengthening primary care. Alma Ata, Health for All, and now UHC. And yet, with a few notable exceptions, primary care remains underfunded, inadequately supported, and inaccessible to most people who would benefit from it. Today's session explores a radical idea that improving care of high blood pressure can not only save tens of millions of lives, but help catalyze broader improvements in primary health care and UHC. I'm looking forward to the conversation, and I'd like to start us off with a brief introduction, but before I do that, what I'll do is just give you a little bit of a scene setter for our conversation. And so if we can go to the slides. The concept of this session is that controlling high blood pressure can be a pathfinder for universal health coverage by strengthening the most neglected part of UHC, which is primary health care. Not only most neglected, but most important. Resolve to Save Lives works around the world partnering with governments and organizations to be part of the Vital Strategies organization, which has as its vision a world where every person is protected by a strong public health system. Our riddle is, when does 50 plus 30 plus 0 equal 100? If we can increase global control of blood pressure to 50% from its current pathetic rate of 14%, which is less than 10% in low and middle income countries, reduce dietary sodium intake by 30%, and eliminate artificial trans fat from the world can save 100 million lives over the next 30 years. Links is a global community for cardiovascular health. We draw together people from more than 80 countries, leaders who are advancing cardiovascular prevention. High blood pressure is the leading preventable risk factor for death worldwide. It kills more people than all infectious diseases combined. And we know that every 20 millimeter increase in systolic blood pressure doubles the cardiovascular death rate, starting at 115 over 75. And what that means is any concern about over-treatment of high blood pressure should be far outweighed by the reality of massive under-treatment of high blood pressure, which is the reality today. An analysis we did in the US a few years back showed very clearly that controlling high blood pressure would save far more lives than any other adult intervention. For childhood survival, there are very important interventions: vaccination, oral rehydration, treatment of pneumonia, and others. For maternal health, there are critically important interventions such as emergency obstetrical care, access to family planning, and for adults, male and female, the largest impact, millions of lives saved, will be treatment of high blood pressure. Interestingly, in that 100 million lives calculation, about the same number of lives are saved by both reducing blood pressure and with treatment and reducing sodium consumption. Primary health care is the most needed and yet most neglected part of the universal health coverage effort. And what we've learned over the past 2 years is that improving hypertension treatment both requires and facilitates improving primary care. We've found that there are many, many barriers, many hurdles to effective primary care. These include the categories of diagnosis, treatment, and continuity of care. And this slide shows it as a race getting to the finish line of blood pressure control, even though we know it's more like a loop because treatment is lifelong. The diagnostic barriers include that when many patients come into health facilities, they don't have their blood pressure taken, or if it's high, the diagnosis of high blood pressure is not made. There may be low attendance at some health facilities, particularly in primary care. Measurements may be inaccurate with poor quality equipment or poorly performed monitoring, and we've learned that digital monitors that are independently validated are crucial under program conditions. In the treatment hurdle, we found that there is often no protocol or an insufficient protocol, that drug shortages are the norm in many countries, that there is therapeutic inertia. Doctors will see the blood pressure high and say, oh, come back in another month, and then the patient won't come back or may have a stroke or a heart attack. That the private sector may be dominant because it's more convenient to patients, but may provide even lower quality care with really no mechanism for providing continuity of care. And the patient flow at facilities may not be efficient. For continuity of care, there may be no reminder systems, no recall systems. The medicines may not be affordable to patients. There may not be an information system to bring people back. And here, at the very end of all of these hurdles, is the problem of low adherence. It's a real problem, but it's only one of more than a dozen problems. The major challenge to hypertension control is not patient adherence. The major challenge is the responsiveness and effectiveness of the healthcare system. Now, my last slide just goes through what we and WHO and other partners have conceptualized as the 5 fundamental building blocks for effective hypertension control. The first is a protocol. A protocol is not a guideline. Guidelines are wonderful, but you treat patients according to guidelines, but with protocols. Protocols are drug and dose specific regimens selected by the country or health facility which are appropriate and will result in control of blood pressure. Now, in the theme of how this is potentially a pathfinder for other conditions, if you've got one evidence-based protocol, you can have others, whether for diabetes or COPD or seizures or any other condition. The second is high-quality medication and equipment. And if we have good blood pressure monitors in health facilities, that's going to help identify eclampsia, preeclampsia, and improve the safety of pregnancy. That's going to help care overall with sepsis and other problems. So this will strengthen the overall system. And if we can improve the logistics for medications for blood pressure, we can certainly improve them for other essential medicines. Third is team-based care, and this will be one of the main themes of this morning's conversation. This is perhaps one of the most neglected and yet most promising aspects of primary care. We know that care delivered by nurses, community health workers, pharmacists is not only less expensive and more acceptable to the patients, it's not only better for the healthcare system and better for employment, but actually it's better quality. And we'll hear more about that later this morning. And this, of course, is applicable to a wide range of conditions. In the United States, for example, if you are on the blood thinner Coumadin and you're not in a nurse-managed clinic, you're getting inferior care. The fourth aspect is patient-centered services. And we need to see how a health system can revolve around the patient. That's the key challenge here. And that's how public and private systems are going to deliver high quality. But that means reducing barriers of time, of distance, of money. That means reducing barriers of communication, figuring out ways to encourage patients and make them part of the process. And finally, an information system to create feedback loops that are applicable to other programs. And we're very excited at Resolve to Save Lives with our simple app, which is currently in use in 2 states in India, scaling up to 2 more countries, we think, by the end of the year. And next year will be available free, open source, interoperable with other systems, and it will always be free and open source, and currently very effective at getting feedback and supporting health workers to support their patients. Because we find ultimately that to deliver quality in healthcare, it's crucially important that we have that kind of information so we can continuously improve the quality of care. Now, with that brief introduction, I'll stop and invite Dr. Myrna Cabotaje to the stage. Dr. Cabotaje has a broad public health background, having worked in field operations, extensively in many regions around the Philippines and within the Technical Bureau of the Department of Health. She was appointed Undersecretary of Health by President Duterte in February of 2019. As Undersecretary, she has been passionate about her country's commitment to boost universal health coverage under the Formula 1 Plus for health policy. I will say that Philippines has really started some very exciting programs and aims to be a global leader in expansion of coverage. So we're very excited, very grateful to have you here, and very excited to learn from you. Dr. Cabotaje.
Good morning, everyone, and thank you, Tom, for the kind introduction. As we are talking about universal health care, allow me to give you a brief background of what our universal health care law is about. It has been recently passed, signed by the President in February 2019 of this year, and it ensures that every Filipino citizen is entitled to healthy living, working, and schooling conditions. And the most important is that every Filipino citizen has access to a comprehensive set of quality health services without financial hardship. While everyone is talking about universal health coverage, our law aptly calls it universal health care because we think it's more than, we cannot equate it with just coverage, insurance coverage. Because in Philippines, coverage, we have equated it to health insurance. So universal health care law is just more than insurance coverage. It includes both the supply and the demand side interventions, and institutionalizes the updated DOH health financing strategy. This is actually a pooling of health funds. And the salient features of our universal health care is to classify our entitlements into population-based. Population-based healthcare services are that which impact on the population and which will be provided either by the DOH or our local government unit. And our individual-based healthcare interventions that is provided through our PhilHealth, that is our health insurance. And there is pooling of funds for these individual-based health services. Another feature of our universal health law is mandating income retention for all government health facilities. That means the income that they get, it plows back, doesn't go back to the treasury. They can use it for their operations. And another thing that we would like to improve on is the submission of clinical costing price data for health providers, so that we can have a comparison across the different health providers, and that will ensure transparency and ensure standardization. And as has been mentioned by Tom, the most important feature of universal healthcare is really primary care package. So we are going to have a single comprehensive primary care package that shall be implemented in health facilities, and this will include lowering of medicines that will be available to our constituents. So that's the short of the universal healthcare law of the Philippines. Thank you.
Thank you very much, and we'll look forward to hearing more about that in the discussion. I'd now like to introduce Dr. Benga Ogedegbe. Dr. Ogedegbe is a leading expert on health disparities research. His work focuses on the implementation of evidence-based interventions for cardiovascular risk reduction, particularly in underserved populations. He's expanded his work globally to sub-Saharan Africa, where he's funded by the United States National Institutes for Health to strengthen research capacity and reduce the burden of non-communicable diseases. I've been privileged to travel with Dr. Ogedegbe in Nigeria and see his effective interaction with our colleagues there and the excitement that his really important research brings. Please welcome Benga.
Good morning, and I'm excited to be here. So my focus is to really think about strategies that can allow us to implement what we know about the evidence interventions for hypertension control. So first, to just characterize one thing that Tom said in his slide. All of those strategies, all of those hurdles that he mentioned are systems level barriers. I'll say one more thing. I think the evidence for hypertension control is saying that we've got to get there, the lower the better. And the faster we get to a low BP, the better as well. So we've evolved to look at what we call the FAST strategy, facilitating access to care and task shifting strategy for hypertension control. This is a program that we launched in Ghana in 2011 with the idea that it would be great if we can figure out a way to actually leverage what the Ghana healthcare system has in terms of its universal healthcare coverage, but overlay on that task shifting strategy for nurses to deliver hypertension care. That program was successful, and we've actually been able to help influence the Ghanaian healthcare policy. In my mind, if we have to address this issue of healthcare coverage for hypertension control, we've got to look at 5 components, and that's what the evidence shows. Solid healthcare infrastructure, health insurance access, human resources for health, that means available healthcare workers at the primary healthcare level. And of course, we've got to also think about the idea that we have the patient-related services. And so all of those components are very important. And finally, policy and regulation. That is where the political will comes in to have a policy in place. We'll be willing to, I look forward to discussing some of these issues in the panel. Thank you.
Thank you very much, and we'll now start a discussion and also invite those in the audience to ask questions. I guess, I don't know if we have a way of accepting questions from, we don't have questions from the internet, so we will represent everyone who's watching by questions and discussion here. Let me start with you, Dr. Cabotaje. How do you think this system will strengthen primary care, and how will it deal with both the public and the private sectors?
Well, in terms of primary care, that is now what we are focusing with the universal health care. Because how can you, it's going back to the basics. That's what our secretary was saying. We want to go back to providing access at the lower level and at the community level. So wherever they are, whether they are in geographically isolated, disadvantaged areas, we hope we can bring the services there. And in terms of the private sector, where there are no public providers, then we can partner with the private sector. The concept of primary health care, universal health care, is you have a province-led healthcare system where one province takes care of its constituents and try to make a healthcare provider network. So at the basic, you have the barangay health stations, you have the rural health units. If there are none available, then we partner with the private sector.
Great, thank you. We'll come back. Benga, can you tell us more about the task sharing trial that you did, what you found, and what the lessons are for other areas?
So this is a study that was funded by the NIH in 2011. What we did was we actually adopted the WHO Best Buy. At the time it was called WHO PEN, Essential Primary Care Program, with hypertension as an entry point. We went to the Ashanti region of Ghana, which typically represents most of Ghana, and we randomized there 32 community health centers to receive one of two strategies. We're really comparing two systems level strategy, provision of health insurance coverage, and addition upon that, a task shifting strategy for nurses to prescribe, treat, and counsel patients for hypertension. And so what we found was that we randomized these 32 practices. We looked at 757 patients. At the end of 12 months, both interventions led to significant blood pressure control. 50% if you have health insurance coverage, 55% if you have no task shifting strategy overlaid on that. The interesting thing is that blood pressure dropped by about 20 millimeters of mercury from a baseline of 156. That's for the systolic BP. And then when we finished the study, we came back in another year, that would be 24 months, to see if the intervention effect was still there. And what we found was striking. Intervention effect remained the same. So what did we find? Both strategies led to significant blood pressure control, 50 to 55%. Both strategies actually led to retention of patients in the healthcare system by about 85%. We did not look at the cost effectiveness of these strategies. And the challenges we had was, of course, doctors have to buy into this. We did a post hoc study where we actually polled the physicians within Ghana Health Services. We had a conference with them. And the reaction was mixed. Half of them were very happy that we had the program because it reduced the patient load that they have. The other half was unhappy because they did not feel that there's a policy in place to allow nurses to prescribe.
So let me ask you both a really broad question. And as we focus again on UHC, and it's very interesting the concept that coverage isn't enough, you have to get to care.
Yes.
But can I get your thoughts of, first, why is it that primary health care is so neglected in so many countries? And more importantly, what can we do about it? How can we change that long-standing neglect so that it becomes recognized as really the most important part of our healthcare system?
Well, on the first question, why primary care seems to be neglected in some areas, because the drama of going to a hospital and you're immediately cured is gaining attention. Thus, the focus of some of the funds really go to the hospital. And patients really want immediate care in the hospital. Why do we need to have it at the primary care? Because this is the prevention level. This is where you can have the regular follow-up, the maintenance. You cannot be going regularly to the hospital. It's just a one-shot deal when you don't feel all right. But I think primary care is important so that at the beginning, you have the promotion aspect, the prevention aspect. When they go to the hospital, it's the immediate treatment. Then afterwards, they are lost to follow-up.
I have, since our visit to Nigeria, I've been thinking about this quite a bit. I think the reason primary care has been neglected is a combination of factors. So if you look at the low-income countries, for example, most of the emphasis, at least I'll speak for African countries since independence in the 50s and the 60s, has been really on hospital-based care. And so at the time, the burden of disease was mostly communicable diseases, so malaria, TB, what have you. With those, is really acute care. And all of that has really focused attention on providing such care. So at the primary healthcare level, what you tend to see, I was born into that system in Nigeria, was maternal child health and then malaria services, all parallel programs. That was important. Infant mortality was high. But I think over time, you have these 30, 40 years where we now see the transition of care in terms of how we looked at diseases. There's a double burden of disease. That hasn't quite caught on. The HIV epidemic actually opened up the eyes of most governments, so the need for primary care. Again, with donors, you have parallel services at the primary healthcare level. Task shifting took off. But we somehow think about this in a very siloed way. The second factor I will really submit is that the health-seeking behavior of most populations in low-income countries is based on acute care. So they're not used to going to a primary healthcare center to receive care for a symptomatic disease, for a disease that they're not even aware of, and for something that they don't think they will get the right care because the trust of the healthcare system at that level is just not there. I often go back to my days doing my internship in Lagos, Nigeria. We get to clinic at 9 a.m. Patients are there from 5 in the morning. And then we clear about 300 patients by 3 p.m. Everybody's gone. I'm like, wow, what happened? Well, people are not, they're not comfortable with that. And that's is a hospital setting, not a primary healthcare setting. So I think those combination of factors have to be grappled with. We have to raise the awareness of the importance of NCDs, and then raise the awareness of the importance of the primary healthcare system as a way to address it.
May I just add
Please.
about the health-seeking behavior? That has been an excuse for many of our community health workers that patients, parents do not, they have poor health-seeking behavior. But I think that's wrong. It's more health literacy. We really need to inform our community so that they can seek health care. So with the universal health care law now, we are very strong on health promotion, really to improve not only the healthy settings in schools and in homes and in workplaces, but also improving health literacy. I think that is one of the basic factors, even for primary care, that you are informed so that you can do appropriate action.
There's an interesting theme here, which is that high blood pressure, specifically, primary care generally, are things that often will address problems that are silent. And in the same way, public health more generally, what you called population-based services,
Yes.
also often address problems that aren't getting the major attention and yet may be having the largest health burden. Can you tell us a little more about the population-based entitlements of the UHC program in Philippines and how those will interact with the clinical interactions?
Well, we are currently, as Mr. was saying, the focus is really on the communicable diseases. So even at primary level in the Philippines, we focus on our TB, malaria. We look at these cases, but sometimes we forget that these packages are already being implemented, but they are implemented in silo. So they are program-based. You have a TB. You do not look at the patient. That's one feature of universal healthcare. It's the patient-centeredness. What we do in the past was look at the programs. So this is malaria program. This is what we should do. This is NCD program. This is what. Instead of looking at the whole patient, so that you can provide the set of comprehensive services from promotive to preventive. With our universal healthcare law, we want now to start with the promotion, prevention strategies, then do the diagnostics that are necessary in the primary care setting. If it is population-based, then it will be paid by the government, our vaccines, our some of our TB drugs. But we will now shift to individual-based. So if it will become individual-based, PhilHealth is going to pay the services through capitation, what we call the per family or the outpatient benefit packages. And then this will be given through the health centers or through a voucher system. For instance, for hypertension, we are now looking at how patients can avail of the medicines through a voucher system. So it's an individual-based package because it only benefits the individual. But we want continuity of medications. So it's provided to the healthcare facilities, the funds through PhilHealth, and the local government or the facilities can now have a voucher to a pharmacy where the patient can access that medicine, or the health facility buys the own medicine that they can provide to the patients. So we are looking at those factors in terms of our population and individual-based services.
Thank you very much. Benga, anything to add on this?
The only thing I will add to that is that I think it's important to recognize that all politics are local. So at the level of the federal governments in most countries, you can take policy and regulation strategies, have a policy in place, but it still boils down to what the local governments are doing.
Yes.
Because in most countries, everything is devolved. So
Yes.
at the local government, what we're doing in Ghana is we're creating an urgency of the issue of hypertension, where we met with the executive director, and then his office then begins to ratchet up programs that really raise the awareness of hypertension. And then with respect to how that can be addressed with health insurance coverage, I think without that, it's going to be it's what you say all the time, the political will just has to be there. I think if you have that strategy, it may begin to raise the awareness level of this.
Building on that, one of the means to generate and sustain political will is to have ways of tracking whether or not we're achieving our goals, and then to make that information widely apparent. How will you know if you're succeeding with your UHC program, and how will we know whether task sharing is really being used in Ghana or all of the places where it would benefit patients and health systems?
For the universal health care, we are now focusing on improving our health information system. We have currently available health information system, but that's not really very robust and not very comprehensive. So with the universal health care system, we want to have a more sustainable health information system like our electronic medical recording system, which we are trying to struggle with. We have the electronic medical record that should be available at the primary level. That has been required by our Philippine Health Insurance so that we can claim for our outpatient benefit packages. If we can just improve on this and sustain it so that we can have better monitoring, evaluation, and even surveillance, not only for hypertension, but other diseases as well.
That's a challenge, Tom. So with our project, it was all paper pencil based. Some health centers had the capacity for AMR, but very rudimentary. What we're beginning to try to use now is we're actually trying to leverage links for simple. I think is important. Where we struggle is this. Ghana has 5-tier healthcare system. They have the community health centers, which is the secondary level, and then they have the health posts. They call them the CHIP zones. People often refer patients to the health centers, but the back referral, nobody's tracking that. And that's what we're finding to be really challenging. So you really don't know at any given time the cohort effect of what you're doing. All you can say is a snapshot. And when we looked at those systems, they were not as robust as we want them to be. So I think there's need for solid data infrastructure. Simple may be a way for us to try and address that.
In every country we work in, we see a chasm between the hospitals and the primary care, and often a gap between primary care and the community as well. This is something that is not going to be easy to bridge. Yes. And I think we need examples from around the world or examples from specific facilities where this is done well. Here in the United States, we have systems like Kaiser Permanente, which are capitated models that really revolve around primary care. In Canada, where they've improved hypertension control rates up to nearly 70%, partly that was done because primary care was the quarterback. Primary care was in charge and driving it. But that's a very difficult approach and turns things on its head in terms of how most health systems function. Do either of you have ideas on how to knit together this system more effectively?
Under our universal healthcare law, we are talking about healthcare provider network. So we start at the primary care package where the patients or the citizens will now try to look for a primary care provider. Our default is the government, our public health facilities, our government health facilities, where they should be enrolled. That is being envisioned now. So that is where they receive their primary care services. And then there is a navigation system that will now bring them to where up referral, where they need to go to the hospital, or down referral. There's a back referral from the hospital, brings back to the where they have been initially enrolled for their primary care provider. It's a little difficult. Loosely, we had a district health system. In the olden times, under the WHO setup, we had the district health system where we had from the from the RHUs, our primary level, then we bring to a district hospital and then goes back. It has not been maintained because of the devolution, and there seems to be a cut in the administration. We want to put it back now with health care provider network, but more importantly, it's the navigation from the primary going back where you're going to refer the patients, and then the back referral. We are also looking on in the future even the step down for our stroke, for our cancers, as part of that healthcare provider network. And the healthcare provider network is not only for government. If government facilities are not available, then private health facilities can also opt in the network. And it's not only also for government. Our private sector can also have a healthcare provider network that if the citizens opt or choose a private care provider for their primary health care provider, then we will allow them to do so. But it's important that we have a network of both the facilities and of providers.
Thank you.
I think that, interestingly enough, there are structures in place in all of these places we're talking about. I think what is missing is really coming up with a strategy to address the contextual factors. So if we have to implement any evidence at all, if you have to implement any strategy at all, there are two factors. One is, do we have the technical evidence? And two is the context. I think if you look at the case of Ghana, they actually have laws in place. The problem is they've not really thought about really creating facilitators within the system to address this. And let me be specific. So when we went to the Ghana Health Services, we created a national committee and we asked them this same question. How can we create a really longitudinal program whereby we start from the CHIP zones to the health centers, back to health centers, and then maybe regional hospitals? And they said, we're task shifting. And we said, well, that's what we want to do. What do you guys think about the policy for that? And they said, we actually have this in place. Why don't you consider task strengthening? It turns out that they've trained people, community health officers, to go to homes, assess patients, right, for prevalent risk factors, and then if you identify them, refer them to the healthcare center. The issue is those CHOs are focused mostly malaria, TB, and if you think about it, HIV. So their primary duties is not being done. So what we evolved to now do is say we need to create facilitators within the system that can begin to actually look at all of these things that are in place and try to make it happen. Now that has to happen at the local level as well. But that's the strategy we're beginning to really discuss with the Ghana Health Services. So some of these things are there. But hypertension may be a way to strengthen that. HIV was a way to pay attention to primary health care, but it really didn't go across the entire system. An NCD that requires continuous monitoring may be something that can help that.
Just two comments from our side. One, indicators have been established by the World Health Organization for hypertension care, and they're very straightforward. It says essentially how good is your care and how much care are you giving. So it asks what proportion of the people that you started treating have their blood pressure controlled to less than 140/90. That's a very simple indicator, not easy to collect, but very simple. And it's a yes-no answer, controlled or not. And then, maybe less frequently, of everyone in the community with hypertension, what proportion have it under control? And that also is a very simple indicator. Those two things give you the quality and the extent of services. that kind of accountability is quite powerful. What we found when we began implementing this in India and elsewhere, partnering with Indian states and Indian leaders, is that if a program succeeds, the volume will be huge. India has close to 500,000 patients on treatment now, just in a few pilot districts. And so, whereas in a program such as tuberculosis, it's really quite possible to get that type of indicator from a paper-based register system. For hypertension with 50 or 100 times more patients, it's probably, maybe not impossible, but extraordinarily difficult to do it. And there have been some programs that have done it with multiple drawer methods of moving patient cards from one to another. But this is what led us at Resolve to create a tech team that has done a fantastic job creating an app called Simple. We hope this will be available to any country next year. And the team, I think, was very creative in working with the nurses and health centers and saying what works for you, and continuously upgrading the app so that they get a follow-up visit down to 24 seconds, so that it gives the information they need, the functionality they need. It uses their own phone. It respects all of the government requirements for data management and confidentiality. What we found in country after country is people will say, we're going to have a great EHR. Come back in 6 months. And what we've seen in country after country, including the US, including here in New York City, when as health commissioner, I did the same thing. I said, we're going to build a great EHR, is that the average time to build something that really delivers value is a decade. And the average cost is in the tens of millions of dollars. So yes, we know that digital technologies have enormous promise, but I think we need to look at new models of those technologies. And we've seen some electronic health records that are delivering useful information in Thailand, for example, and we hope that Turkey will also have that. And we've seen some apps that we think have even better functionality than the Simple app does in China. So there are many ways to do this, but getting regular feedback, I think, is going to be crucial to progress. And my concern is that if we just wait for this perfect EHR, we're going to be waiting a long time.
I cannot agree with you more. Our indicators for hypertension is really reduction in premature deaths from CVDs. And we have our registries for hypertension, but it's just a registry, how many have hypertension and how many got treatment, but we do not really monitor how many have been controlled. And I agree with you, that should be the critical indicator, but it will be difficult to track over time unless we have these easier technologies that will help us do the monitoring. But I think we do not even need to monitor it at the national level. If they at the local level can just analyze their data and do something about it, it will be great.
I completely agree. In fact, in Ghana, there's something called DIMS, Department of Health Information Management System.
Yes.
And the idea is that you're going to collect that data from the CHIP zone, and then you're going to ratchet it up. They report the data every 3 months. And when we looked at that, it was very cumbersome. How many have you controlled? They have a sense, and it's a snapshot. They don't have a sense of the community level control. So I think, and we're negotiating with them now on the idea that maybe we should look at Simple. And one thing I think would be helpful is the copycat mentality. If it works in one region, you bet the next executive for the adjoining regions will want to implement the same thing. So we're hoping that in the Brongo-Afo region with Ketampo Health Research Center, if we can adopt Simple, hopefully the Ashanti region will do the same thing as well.
I'll just mention, since you say fundamentally what we're trying to do is not control blood pressure, but reduce premature death.
Yes.
That one of the other important programs at Vital Strategies is to strengthen civil registration and vital statistics around the world. And this is part of the Bloomberg Philanthropies and Australian government-supported Data for Health initiative. And crucially important, if we can't count and accurately understand the causes of death and where people are dying and at what age and from what and what could be done to prevent them, we won't be able to hold ourselves accountable ultimately. And those systems are far too weak globally. Let me shift slightly to talk about the private healthcare sector. In most countries, this is of large and, in some cases, growing importance. And yet there are a limited number of models for how we can ensure quality in the private sector. Any thoughts on this, or suggestions of at least what we might do to explore and evaluate going forward? It's a tough question, I have to say. In tuberculosis control, we've been struggling with this for 20 or 30 years with honestly, very limited progress.
With tuberculosis, we have in the Philippines the notification law where private providers, private healthcare providers are mandated to report now. But it's the enforcement that's the problem. But in terms of hypertension and NCDs, we have not really established, except that if they now we'll have to wait how the universal health care will be implemented, but they can also now, the private care providers can also be given PhilHealth resources. They can be reimbursed for outpatient benefit packages, provided they follow the requirements. And I think, as I mentioned earlier, the other thing is to be able to mandate the submission of the reporting system, even their costs eventually, but I don't know how successful we can become by asking them to submit to us how much their packages will cost, their maybe professional fees, or just how much a case rate for their service packages for NCDs.
Most broadly, I think many governments initially were trying to implement all care, now recognize that a lot of care will be given in the private sector,
Yes.
and so are ratcheting up their ability to monitor and regulate the quality. Even if they don't provide, they should at least try to ensure quality. Benga?
I have two thoughts on that. I think what comes to mind is what Brent Egan, used to be at MUSC, did with rural healthcare in South Carolina. So as part of the American Society of Hypertension, we're all hypertension specialists, the idea was, if you look at rural healthcare in the US, it's the same issue, right? Most of the people providing care there are actually private. And so what Brent did was said, okay, what if we control the quality of care that they provide for hypertension, and we make them hypertension specialists? What I'm thinking is that one way to think about this is this provider network. If we look at the private healthcare, the least we can do is to figure out a way to engage the providers on the protocol, at least for hypertension care. If we can do that and then show them how that can improve their reimbursement, I think at the very least we know they're providing quality care. Now the cost is still high for the patient, but at the very least they're providing quality care. And if you can have them track how well they're doing that, I think that's something for us to consider.
So, two thoughts about that. I think Brent Egan and Norm Campbell are two individuals who for more than 20 years have been voices in the wilderness, advocating for hypertension control, but really making a difference. Mm-hmm. Canada now near 70%. I remember one of Brent's first studies, he collected doctors who were volunteering to participate in a collaborative effort to improve the quality of hypertension care, and he had them send in postcards for each visit of each patient, and then he analyzed those postcards. And what he found was really fascinating. In a self-selected group of people who wanted to focus on hypertension, when patients came in with blood pressure out of control, the medicine was intensified only 13% of the time. So it really showed how far there was to go, even in the self-selected group. Mm-hmm. And one of the things that we found in a few countries is the private sector is private for a reason. They are incentivized by funding, by money. And so if we expect a private sector model to work, it's going to have to address the financial incentives. And if the financial incentives are to prescribe expensive medications that are no better than protocol medications, that's not going to be a way of encouraging the protocol. So I don't think we've figured out the answers there yet, but it's certainly an important area. We have people in the audience here. Maybe we'll open up to questions. questions from the audience. We have a microphone, I think, that can go around. Funke has it, and just raise your hand if you have any questions. Meanwhile, we'll continue our discussion here if there are none.
Hi, good morning. My name is Frieden. I'm Peter Molinaro. I'm a retired cardiac surgeon who recently got my MPH, and I have two questions, actually. One of the reasons in America that are commonly cited for the lack of interest among medical students going into primary care is the fact that they feel the need to pursue higher paying specialties to pay off their student debt, student loans. I'm wondering, several medical schools have moved towards reducing or eliminating tuition and thus student debt. I wonder if you think that may lead to more students choosing to go into primary care specialties. And my second question is this debate that's going on that it's reached The Economist in the lay press about the administration of some sort of cardiovascular polypill to individuals who have not been screened for lipids and hypertension. There are people ferociously in favor of it, and then a whole other group that consider it overtreatment. And I'm wondering what your opinion is regarding that. Thank you.
Two great questions.
I can try the first question. I'm at NYU School of Medicine, and so our institution actually is the first to actually make tuition free from August of last year. And I'll further to say that other folks are doing it, but they're not doing the way we're doing. They're saying we'll reduce the need. We're saying we don't care about the need, we'll pay for it. Now, will that lead to more students going to primary care? I think that's a debate that's been ongoing for the past 20 years. When I was in training, the idea was that if we have universal healthcare coverage, as proposed by President Clinton at the time, the hope was that most of us would go to primary care. And there was a vast expansion of family practice programs.
Yes.
And a lot of people did that. But then again, it waned off. I don't know that it will lead to that, but here's what I know. I know that it will allow medical students to actually pursue what they want to pursue. Here's what I think the problem is. Students come to medical school, we mentor them, and what do we think is more glamorous? When they get to do those electives, by the time they leave the primary care program, which I'm a die-hard internist, they do those electives, it's more fancy. By the time they're in their fourth year, it's all about electives. So we're modeling a system for them that really is reinforcing the idea that specialty care is the way to go. With respect to the second question about polypill, I have my own bias. I think it's a great thing. I don't know that we should be giving polypill to everybody, regardless of whether or not they've been screened for hypertension and other cardiovascular risk factors. I think the major issue is cost. If you show us the polypill that is as cheap as a combination diuretic and an ACE inhibitor, or calcium blocker and an ACE inhibitor, and it's cheap, then no problem. Study came out from Singapore where they've showed that that is effective. Study came out recently in the US, showed that's effective. I think it's a no-brainer that's effective, but the idea that we should just give it to everybody, I don't subscribe to that, because it takes away, from the idea. I mean, what do people want? I think the cost is going to be really very important for low resource settings.
May I answer for the Philippines only the first question? In terms of luring our medical students to go into primary care, there has been an existing scholarship program, although now we are enhancing it in our universal healthcare law. So we provide scholarships for our medical students who would like to become doctors, with the end in mind of bringing them back to practicing primary care. Also in the universal healthcare law now is the interaction with our Commission on Higher Education, in charge of our medical curriculum, and our Professional Regulation Commission, that will now try to restructure the way the medical curriculum is going, so that it's focused on primary care. Of course, you know that the Philippines is one of the producing so many specialists all over the world. My class, for instance, College of Medicine, More than half of my classmates are in the US for specialty practices. So what we are now trying to do with the universal healthcare, you'll be surprised because we are now incentivizing primary care packages. Even our specialists, those in family practice, would like now to be the primary care providers. But the law is strict that there should be some certification for these primary care providers. But what is important is really the incentive that PhilHealth or the government can provide when you do primary care practice. But you'll be surprised, many of our doctors now want to go back to primary care. We have our Doctor to the Barrios program, if you have heard about them. These are a group of, this is a program in the Philippines where we provide higher incentives also, salaries for doctors who go to the far-flung areas and practice. And Dr. Kenneth is the master producer of all of these Doctor to the Barrios. And we have about 100, more than 100 doctors who are going to the primary care areas.
I just say one more thing, one more plug-in for NYU. We actually just launched a medical school that's purely focused on primary care. It's going to be in Long Island, and first class, I believe, started last year. And that's, I think, is movements like that that can start to make it very, very important for us to focus on this.
And maybe just follow with the issue of the glamour. I mean, Atul Gawande has written an article called The Value of Incremental Care, and he describes the reason that he was fell in love with being a surgeon was because he saw a splenectomy during a trauma case. But now, all these years later, he has recognized the fact that preventive care, primary care, will save many more people than this very dramatic, kind of glamorous emergency surgery.
So I think we've heard about the image of primary care, but we've also heard, and we're in New York City, so we can say it, money talks. Yes. And specialists in the US make twice what primary care practitioners make. So it really doesn't take a lot of brilliant research to figure out why people are more interested in going into specialty care than primary care. I do want to say on the polypill, these are complicated topics. So I would think broadly there have been 3 different types of approach to cardiovascular prevention. One has been the polypill discussion. And that discussion gets important to be a bit nuanced. It used to be that aspirin was believed to be clearly indicated for primary prevention of many people, particularly high-risk people. It's now far from clear that aspirin benefits anyone who hasn't had a heart attack or a stroke before. If you've had a heart attack or a stroke before, you certainly should be on an aspirin. Statins, to lower lipids, very, very smart people disagree about the role of statins in primary prevention. We know that eliminating trans fat will help your lipid profile. We know that reducing sodium will dramatically reduce your blood pressure. We know that a healthy diet and more physical activity will be really good for you. And we wouldn't want you to think that you can take a pill and not do any of those things. Because they're much better proven than the pill. So where you stand on statins is going to determine where you stand on the polypill, I think, at least in part. But the concept that there's a heart vitamin that everyone will take, that's a difficult concept to see done. Even when there's a diagnosis, the rate of adherence is relatively low. But then we get to the blood pressure components, and we're strong adherents of fixed dose combination of antihypertensive medications. We, along with colleagues from the George Institute and elsewhere, submitted an application to the World Health Organization to add 2-drug fixed dose combination drugs to the essential medicines list. It was approved. So now for the first time, we have 2-drug combinations approved. The George Institute advocates for 3-drug combinations, which may well be indicated. There is some strong evidence for them. We need to look at costs, and we need to see why can't we get the costs of 2-drug combinations down to the same or lower than individual drugs, because You have one pill instead of two. You have one package instead of two. They're both generic. You have a tableting that should leave you some efficiency, but instead we're seeing higher costs for the combination drugs. The second broad approach, in addition to polypill, has been to try to find the highest risk people and only treat them. And we think this is a problem. It's a problem ethically because you're not offering an accepted treatment, something that's been standard of care for 50 years in rich countries, to people with high blood pressure, a life-threatening condition in low and middle income countries. And we also think it's a problem operationally, because the programs that have spent a lot of attention trying to find which of these patients are high risk end up treating very few people. And if you just say, if your blood pressure is high, we're going to treat you, you may well end up treating many more high-risk people than you would with that risk-stratified approach. But certainly, to stratify risk and say these people are at really high risk, we're going to give them much more intensive care and make sure they get care, that makes perfect sense. But the approach that Resolve to Save Lives and our partners around the world have taken is a hypertension entry approach. If your blood pressure is high, you should be treated. It's a condition that needs care. We also want the population-based services, but even if we're wildly successful with sodium reduction, there are going to be 1 billion people in the world who need treatment for high blood pressure and will benefit from it. And we know that lower is better. Since the SPRINT trial, this was debatable. We knew that mortality goes up at 115/75, but until the SPRINT trial came out, we didn't know that mortality would come down when you came down with treatment. But in fact, the SPRINT trial has answered that question definitively. The death rate for people treated down to 120 was 27% lower than the death rate of people treated to a target of 140. Lower is better. So we think that the risk of overtreatment, again, is far less than the risk of undertreatment. Polypill is interesting. Anything that makes it easier for patients, simpler for healthcare system, has promise. Fundamentally, each country has to determine for itself what the policies it wants to have are. One of the things that's been fascinating to us over the past 2 years, and we've got an article that just went online, and it's here for those in the room, on the lessons learned from the first 2 years of the Resolve to Save Lives and WHO and other partners' work, is that in more than a dozen consensus conferences in more than a dozen states and countries, the doctors, primary care specialists, pharmacists, program managers have come up with a real consensus on what the medications should be. Every place, virtually, has started with amlodipine, a calcium channel blocker, as the first drug. It's the safest, it's cheap, it's generic, it's effective, it's once daily, it has no life-threatening adverse effects. You don't have to check any lab tests to get it started. So after that, though, there's a little bit of divergence. Should you use a fixed dose combination? Should you use one drug or another? What's what's safest and least expensive? And as a tuberculosis doctor from way back, I'm a little startled that studies haven't been done to optimize the hypertension regimen practically under program conditions. What works best? So we hope in the next few years that will be determined. Programs change and evolve, and they change and evolve based on data, looking at the data to improve performance. And Dr. Cabotaje, your work in Philippines, I think, is showing how can we get care out into the community most effectively. Dr. Ogedegbe, your work in Ghana and elsewhere is showing how can we really make team-based care part of a team and effective in that way. And we're all looking forward to learning from you in the years to come. Do we have any other questions from the audience? Yes.
Hi, I'm Rachel Moreski. I direct a program at Columbia called SIDHEART, Strengthening Emergency Care Systems, mainly in Ghana and Rwanda for the last 12 years. Like your comment, I think it's interesting, a lot of us specialties have moved into primary care, thinking partly because we're public health, I think trained, or I know I've shifted to Mailman School of Public Health fully. My question is, when we think about, we've worked in Kintampo, Brangahafo, Ashanti, Northern, now we're in Northern Volta and Upper East. And so we've been working on acute care systems and integrating that with primary care systems because we seem to be siloed. Our funding is siloed. We look at mortality and not morbidity. We're funded to measure mortality, right? And so I think it has changed the way. But I would push back on one thing, and I do have a question, is that acute care in Ghana at least, has really been for communicable diseases, right? There hasn't been a referral system or a network for NCDs, and the back referral system, I think, is where we're missing the connection between primary and acute care systems. And if the health-seeking behavior is for acuity, why not leverage that in the community to say, you know what, we caught your hypertension, because people often, as we know, in hypertension don't present until they're symptomatic, that if we catch them at the health center or district level hospital when they have symptoms, that back referral is so critical, and we don't focus on that because it's not primary care, it's not acute care. And just to sort of get your thoughts on that. We've also been working with GHS for 12 years and have an emergency neonatal obstetric care working on DIMS. And getting, if we can't collect the data, right, we can't actually monitor and measure it. So we've been struggling with the same ideas. But just to get your thoughts on the connection between acuity and how we maybe have misnamed it, because I don't think that Ghana actually has a very good acute care system that intersects with primary care. It's more health-seeking behavior for communicable disease is acute. That's my commenting question.
So that's a great point. You actually just made my point, which is that the infrastructure is there, at least in Ghana. What is not there is they haven't strengthened the tasks of people. So I will push back a little bit more. We just met with the Secretary of Ghana Health Services. We met with the person in charge of policy, that's Dr. Kokua Williams. And it was very clear that at the CHIPS zone, what the community health officer is supposed to do is actually identify cases. You have a pool of 5,000 people that you have to go to their homes and then refer to the health center. And I think what he's saying is that this is not task shifting, that is task strengthening. And we agree with that, and we're borrowing that term. And the idea is that if there's a way to facilitate that so that the CHOs are actually doing what they've been trained to do, then you can see the system begin to work. The danger in waiting to look at the acute setting for addressing these issues, at least for hypertension, is that by the time you do that, in the old days, it used to be heart failure. These days, it's dialysis. So when those patients show up, dialysis. I'll tell you a personal story. 1994, I was an intern at Montefiore. My uncle was 45 years old. He had very bad hypertension. This is Lagos, Nigeria. And he saw the doctor, my brother's friend, who said, look, your kidneys have failed. They had only 3 dialysis units in the whole of Lagos, serving at the time 15 million people. Today in Lagos, you can get a dialysis unit anywhere you want, in any region of Lagos. So the point I'm making is that, and all of that is driven by hypertension, some by diabetes. The point I'm making is that if we have to wait for acute care as a way to, okay, or as an entry.
Wait, I'm saying that why can't it be bidirectional, right? If we think of it now as these silos to go to community, we've been working with SHIPS and Kogu for a long time, but that it can be bidirectional.
Right.
So
I think if I'm understanding correctly, one of the things that we've seen in many countries is that people are coming to the hospitals in large numbers, and they're not being their blood pressure isn't being checked. If checked, they're not being diagnosed. If diagnosed, they're not being referred to primary care. And here we've seen really, there's an old saying that for every complicated problem, there's a solution that's quick, simple, and wrong. And what we see often is the big idea to let's go screen everyone in the community. And maybe there's a role for that in some situations, but actually, why don't you start with the people who are coming to your health facilities today? Make sure that they're there. It can be the patients, it can be the parents, it can be the people accompanying people, and then have a tight system to get them into care and retained in care. This is a critically important way of case detection. It's sometimes called opportunistic screening, which is a terrible term. It sounds bad. But basically, it means that we're providing universal screening in healthcare facilities and universal treatment and creating that link between the heavily utilized facilities. In one country, we did a quick analysis. There were 4, in one district, there were 4 large hospitals and 30 primary care centers. But if you looked at the footfall, at the number of patients coming in, there were more patients coming into the 4 hospitals than all of the 30 primary care facilities. So if you're going to try to increase the number of patients on treatment, you have to start with where the patients are. We're on the theme of money again. Sutton's Law. Willie Sutton, bank robber, asked, "Why do you rob banks?" He said, "Because that's where the money is." Why should we screen patients for hypertension in hospitals? Because that's where the patients are.
Although let me address something.
And that was my point.
Yeah.
Also that we don't refer back well from the hospital, right?
But let me tell you why. The reason you don't refer back well is because there is no policy in place that you can treat NCDs at the community health centers. There's a reason for that madness. So there's a method to it. There is no policy that allows. Doctors are not even at the health centers except if it's urban areas. So the notion, the patients are very smart. So they will not go there because if they go there, they're not going to see a doc. Even if a doc is there, the doc is there probably on a monthly basis. So where would they go to the hospital? So the idea that you can refer back is actually, there's no policy or regulation to guide that.
In other words, to strengthen primary care, there's no shortcut other than strengthening primary care. Let me see if there's one other quick question from the audience, and then we'll have final comments from our two guests, and I'll make some concluding remarks.
Maybe I'll come over here behind the camera. Hi, Julie Becker. You've been talking about the idea of using hypertension care as an entry point for strengthening primary care, and primary care as an opportunity for strengthening hypertension care. And I guess I'd like to ask the inevitable question about vertical programming. And what is the vision? So we still have the traditional focus on maternal and child health. That hasn't gone away. We still need that. We are in a little bit of an epidemiological transition. There are other NCDs as well. You know, I understand the idea of addressing hypertension as one of the highest causes of mortality as a good way to start. So what is the vision for broadening, for using hypertension as a way to broaden quality primary care across a range of health areas?
Any quick?
Yeah, that's a great question. I think the same will be true for diabetes, sickle cell disease, any other chronic disease. I think the vision is that if you have a solid monitoring system in place that collects data on hypertension, you will do the same for all those clusters of risk factors, diabetes or what have you, right? The second issue is that because hypertension requires continuous monitoring, the same will be true for things like diabetes. But they're less prevalent, right, than hypertension. And the way to address the vertical issue is just have a policy that says that you can actually have healthcare workers, nurses, physician assistants, non-physicians, to actually begin to not only screen for these risk factors, but actually treat them. I think hypertension as an entry does two things. It's the highest burden we'll see in any primary care program, right? And frankly, from what Tom has shared with us, if you can reduce the mortality by 50%, if you can improve BP control by up to 50%, you save significant number of lives. I think it's expandable. It's a question of how do we do the first thing first, and then from there, we can overlay on that all the other stuff.
Under our universal health care, we're supposed to have a set of primary care packages. So it's looking at the patient, what are the, for a specific age group, what are the more common diseases that we see, and hypertension can come in. In the Philippines, we have our risk assessment. So it's part of our primary care package. Anybody who comes in 20 years and above, we have a long list of assessing. We call them the Philippine package for essential NCDs. And I think that will be a good way to, as Doctor was saying, we will be able to monitor. Because not like the many other diseases that you only see them once or twice, for those with hypertension, they need to be regularly seen, they need to be regularly monitored, they need to be regularly provided medications. So that, and then we can refer them to our levels of care depending on their status of the disease.
So it's a great question. There are ways in which improving hypertension care sets a pathway for evidence-based care, team-based care, regular logistics. But I think it's also important, and one of the reasons perhaps that primary care hasn't made as much progress is that it's sometimes seen as kind of this lump. We're going to give primary care as a commodity,
Yes.
rather than say it's going to achieve certain goals and we're going to hold ourselves and the system accountable for those goals. And one of those goals is controlling blood pressure, because that'll save the most lives. And systems can set whatever other goals they want for diabetes or sickle cell or seizure disorder or others. But you have to have that specialty, not vertical, but focus on a specific area, or you don't get the kind of quality improvement. We see very good primary care systems around the world with very low hypertension control rates. Now, they can improve them quickly, but only if they focus on it. We're just about out of time. I'll make a couple of comments at the end, but anything very briefly that each of you want to say?
I think it's exciting times. We've got to focus on those key components we talked about if we have to improve hypertension control in the world, and that is a solid healthcare infrastructure, and that's where the data monitoring systems come in. Healthcare workforce, where we can begin to task shift strategies at the primary care level to non-physicians. We've got to have health insurance coverage, and that's why the universal healthcare coverage becomes very important. Now, of course, all of that will lead to patient-centered care.
Dr. Cabotaje?
Yes, the same. We need to improve our systems, which includes the supply chain, the information system, and in the end, we really have to focus on the patient, that we did something for the patient.
So just to tie together some of the themes we've heard: politics, care, not just coverage, including population-based care, not just task sharing, but task strengthening, strengthening whole systems from hospitals to primary care to community health workers, strengthening information systems, ensuring accountability for specific outcomes, engaging the private sector, including through encouraging protocol-based care, addressing the incentives, and money, making sure you show me your budget, I'll show you your priorities, that funding is going into primary care. I want to thank all of you for coming, all of you who've joined us on live stream to this Links Live event. If you're not members of linkscommunity.org, please join. Thank you so much, Dr. Myrna Cabotaje and Dr. Olugbenga Ogedegbe, for joining us today and sharing your wisdom and insights. And special thanks to the staff of Resolve to Save Lives and Vital Strategies staff for organizing this event. And this will be available on the Links website at linkscommunity.org. Thank you very much.